Good morning, everyone. My name is Saeed marzooqi. Thank you for inviting me today to give this talk. I was asked to give a talk titled Liver Cirrhosis, What to Do and Not to Do. When I saw this title, the first thing that came in my mind is let's talk about a couple of cases that I think we can learn from. The first case is Mr. M. He is a 48-year-old male. In 2017, he was diagnosed with hepatitis C. Ultrasound done at the time as part of the workup showed coarse liver with nodular surface. He received direct-acting agents therapy, and SVR was confirmed, i.e. the patient was cured from hepatitis C. The patient was then lost to follow-up with his gastroenterologist, and then he came to your clinic, in the internal medicine clinic, in the following year for dyslipidemia. He's otherwise well. The examination is unremarkable, and the labs showed the following results: ALT 20, AST 40, platelet count 160, INR 1.1, albumin 40. The question for the audience, and you can shout out the answer if you want, what will be your next step? So you're seeing this patient for dyslipidemia, and he was treated for hepatitis C, and this is his history. Okay. So medications, lifestyle, that's what I'm hearing. So this patient, he's been managed adequately in terms of his dyslipidemia, and then he's lost to follow-up. And then a couple of years later, he comes to your clinic with abdominal discomfort. You do abdominal ultrasound, and you find 3 liver masses with portal vein thrombosis. The patient undergoes CT abdomen, and this is just an example, not for the patient, but you can see here, I don't know if that doesn't work, okay. So anyway, there is an arterial hyperenhancement in the arterial phase, and the delayed phase, there is washout. So what's the diagnosis? Yeah. So this patient has hepatocellular carcinoma. The patient was discussed in an MDT meeting, and the decision was this patient is not a candidate for liver transplant. We'll go with systemic therapy, and unfortunately, there were no curative options for him. The pitfall in this case is missing an opportunity for HCC screening in a cirrhotic patient. This takes us to hepatocellular carcinoma risk factors. There are different risk factors which are mentioned in the right table, but the most important and common one is cirrhosis. If we round up all patients who have hepatocellular carcinoma, 90% of them will have underlying cirrhosis. The annual incidence of HCC in cirrhotic patients is around 2 to 4%. Any cause of cirrhosis may lead to HCC, but there are certain causes that may have a relatively lower risk of causing HCC in cirrhotic patients, including Wilson, autoimmune hepatitis, and cholestatic disease. It's mostly the gender is male to female predominant 3:1. The age is more than 45. And there are some case reports about patients who have common liver conditions like NASH who may develop HCC in the absence of cirrhosis. It is well established that HCC screening improves survival in patients who are at risk, and namely here patients who have cirrhosis. This is an example of an older study where they randomized around 20,000 patients who are at risk of HCC to 2 groups, the screening group and the control group. And it was shown that applying screening in these patients reduces mortality by 37%. The best modality for screening is ultrasound. The benefits are the cheap cost, the wide availability, no radiation exposure, the benefit of early detection and improving survival. And the sensitivity for ultrasound in detecting HCC at any stage is around 84%. And at early stage is lower at 47%, and that may improve by the addition of alpha-beta protein. This table shows you the different guidelines by different societies about the best modality for HCC surveillance, and all of them agree that ultrasound should be the cornerstone of your surveillance every 6 months, and you can add alpha-beta protein depending on which guideline do you use. In my own practice, I do both. So what if we diagnose this patient? Let's say when he came to you with dyslipidemia in 2018, you picked up on the fact that this patient had cirrhosis, if you did the ultrasound, would things be different? This is a busy slide. I will not go through all of it, but it just gives you a snapshot of what we use and whenever we discuss these cases in our MDT rounds, and this is based on the Barcelona criteria. I'll just take you through this part, which shows you what we do with patients who come to us with early stage HCC. And if you can see below, the options include ablation, resection, transarterial chemoembolization, and transplant. The survival with these options are generally favorable. And for example, in a patient if has the correct criteria and undergoes transplant, the survival would be much more than 5 years. On the other hand, if the patient comes to you in an advanced stage, your options are limited to systemic therapy with a survival around 2 years, or best supportive care with a very poor survival. So what are the lessons learned from Mr. M? Any patient with history of liver disease, a patient who has hepatitis B, hepatitis C, any kind of liver disease, always look in the history if there is anything to suggest that this patient has advanced fibrosis or cirrhosis. Cirrhosis increases risk of HCC. If the patient is not following with a gastroenterologist and seeing you for any reason, please remember that and make the appropriate referral. Patients who are cured from hepatitis C, the vast majority of them will not need any monitoring, but if the patient has underlying advanced fibrosis or cirrhosis, the risk of HCC is reduced. However, it's not eliminated. So please don't forget that. And finally, this case highlights the role of internists and primary care providers as a safety net. Okay, so we'll go to the second case. Mrs. H, 38-year-old female. She was diagnosed with hepatitis B, hepatitis delta cirrhosis. She's decompensated. She had 6 admissions for ascites drainage, 1 episode of SBP, 2 episodes of hepatic encephalopathy. She has poor compliance with clinic follow-up. She's mostly seen the ER on whenever she's hospitalized. This time you are seeing her in the ER, and she presents with abdominal pain, fever, and jaundice. Patient is oriented, answering most of the questions, but she's a bit drowsy. Her vitals, blood pressure 80/55, heart rate of 100, O2 saturation 90% on room air, respiratory rates 28. Labs revealed the following results: ALT 110, ASC 160, alkaline phosphatase 120, total bilirubin is 210 millimoles with direct of 180, that's high, white cell count 20, platelet count 55, INR 2.6, albumin 20, and a creatinine 220. That's more than 2 milligrams per deciliter. Ultrasound shows moderate ascites and portal vein thrombosis. Now you are admitting this patient, you're the internist who were asked to admit this patient in the ER, and if I ask you to write one admitting diagnosis, what would be the diagnosis? You can shout out the answers. Any takers? You can't hear. Okay. So I'm hearing SBP. Okay. So the actual diagnosis here, acute on chronic liver failure, ACLF. What's ACLF? ACLF is a decompensating event in a patient with chronic liver disease or cirrhosis that leads to activation of a systemic inflammatory response and is associated with a high short-term mortality in the setting of multi-organ failure. The key words here are multi-organ failure. The common triggers are sepsis, active alcoholism, and relapse of chronic viral hepatitis. Up to 50% of the cases of ACLF have no identifiable triggers. And you should understand that this is different from the regular cirrhosis decompensation. This is not a patient coming to you with tense ascites that you're going to drain and discharge within a couple of days. This is not a patient who comes to you with hepatic encephalopathy who wakes up within 12 hours with lactulose enemas. This is different. There were multiple diagnostic criteria suggested by different consortia to define ACLF. Okay, but the main theme here that there are other organs that are involved. And the definition of these organ involvements were also discussed and defined by different societies. We'll try to apply this to our patient. You can see here the type of the failure and then the definition for each one. So let's say for the liver, the patient has high bilirubin, so liver is check. Kidney, the patient has AKI, is check. INR is very high, coagulation is checked. Patient has soft blood pressure, circulation is checked, and patient's hypoxic respiratory system is checked. So now when you look at it this way, it goes from, let's say, sepsis, SBP, and all that, and it changes to something more sinister. This is a patient who have multi-system involvement, and the patient, when you look at it, is actually sicker than you thought she will be initially. So why is it important to identify ACLF? ACLF carries a very high risk of mortality, and depending on the grade of ACLF, and that's basically based on how many organs are involved, the higher the grade, the higher the mortality. And if we apply this to our patient, when we checked all these systems, she has grade 3 ACLF, and with that, the mortality, the short-term mortality is approaching 75%. So this is just to show you how serious is this. How do we manage ACLF? I will not go into the exact details. This is a topic that will be an interest of critical care physicians. But the main outline is you need to address triggers and address system failures. And if you do so, then you have to think about liver transplant. And thinking, like identifying ACLF and thinking about liver transplant is very time sensitive. To demonstrate that here, I'll just show you this graph. It shows you 3 types of liver failure. We have the red line is acute liver failure, the blue line is acute and chronic liver failure, and the orange line is chronic liver failure. On the, you can see, maybe I can't see it. And you can see on the left the medical acuity, the higher it goes, so this is your window for a liver transplant, but once you hit the line, the dotted line that says high, then this patient is too sick for liver transplant. And the window that you can see in the orange is you have a good long time that you can consider liver transplant if the patient has chronic liver failure. But in cases of acute liver failure and acute and chronic liver failure, the window is pretty narrow. And the reasons for this narrow window is that when a patient presents with acute liver failure, with acute and chronic liver failure, usually they have some contraindications for liver transplant. And those include active infection, high pressure support, significant pulmonary hypertension, severe respiratory failure, in addition to other causes. But if you address some of them and the contraindications for liver transplant are out of the window, this is the time that you should act. So we'll go back to Mrs. H. She was initially admitted to the HDU. Pan cultures were negative. She was started on antibiotics for 5 days empirically. She was resuscitated with fluid and albumin. Paracentesis was done, and there was no SBP. At 5 days, patient clinically improves. Her AKI improves. She's more alert. The blood pressure is fine. However, her bilirubin is just creeping up. So the decision by the treating doctor at the time was to observe her. Within 5 days, the patient deteriorates again, and then she passes away within 3 days with septic shock, progressive encephalopathy, and respiratory failure. So the next question is, was there an opportunity to save this patient's life? If I go back to the previous slide, when we decided that the patient looks better, looks fine, we're just going to observe the bilirubin, maybe this was our window. These 5 days before she got worse, this was our window to when the infection was out of the way and there was no clear contraindications, this was our window to refer the patient for liver transplant assessment. However, this window is a short window and it was missed. I'm just going to skip that, okay. So other than that time, these few days while she was admitted, was there anything else that we could have done for this patient before this admission? This patient was admitted many times with decompensating events, with ascites for drainage, with SBP, with hepatic encephalopathy. And you can see here on the chart of the progression of liver disease that she had missed liver transplant listing opportunities. So we should have not waited all the time for the patient to present with this significant ACLF that she couldn't survive from. So what are the lessons learned from this case? Whenever you have a patient with cirrhosis, look at the whole picture. look beyond compensated versus decompensated cirrhosis. It's very important to identify ACLF. Sorry, can you show the slides, please? It's important to identify ACLF, and appropriate management and timely referral for liver transplant can be life-saving. You have a limited window. Don't wait until it's too late for liver transplant. And for a patient who comes to you with multiple admissions with decompensated cirrhosis plus minus ACLF without liver transplant referral, this is my personal opinion, but I think this is a risky gamble with the price paid by the patient's life. Thank you very much.